Good afternoon, everybody. I am Dr. Trupti, and I would like to thank Dr. Sunita
She is our fellow. So
to give me this opportunity. And thanks to all of you. Before my presentation, you have discussed many interesting cases. So I'll be discussing two of the interesting cases that I worked up. So as we have already discussed,
slides.
slides.
They were sitting only.
So, anterior segment dysgenesis is an inherited condition characterized by developmental anomalies of anterior segment. Many of the disorders also involve systemic abnormalities. About 50% patients of Axenfeld-Rieger develop glaucoma. PTEX2 and FOXC1 gene mutations are the known genetic heterogeneity, and recently mutations in FKHL7, CYP1B1, and PRDM5 gene have also been identified. Next. Okay. So coming to our case one, so it's a 13-year-old female who has been following up with us since the age of 4 years. And on presentation, the parents came with a complaint of nystagmus and alternating exotropia and a suspicion of glaucoma. So she had megalocornea in both the eyes, and examination under anesthesia was advised. And we found that the corneal diameter was 13.5 mm in both the eyes with a posterior embryotoxon and a shallow peripheral anterior chamber depth in both the eyes. Axial length were within normal limits. IOP was 26 and 28 mm in both the eyes, and cup disc ratio was within normal limits, and CCT was also within normal limits. So after examination under anesthesia, diagnosis of Axenfeld anomaly was made, and patient was started on anti-glaucoma medications. And since then, the patient has been following up with us regularly. In 2019, her systemic examination showed oligodontia, and she had vision of 618 in the right eye and 66 in the left eye. She again had megalocornea in both the eyes, as we can see in this image, and a progressive peripheral anterior synechiae was present. And her IOP was 22 mmHg and 25 mmHg on 3 AGMs. And so this is the image of the right eye, where we can see a posterior embryotoxon in this image and a loss of normal color and pattern of the iris. And over here in this image, we can see atrophic patches and thinning and pseudo holes present. Similarly, in the left eye, we can see an irregular pupil and an ectropia on UVA present with atrophic iris patches and a posterior embryotoxon also present. On gonioscopic evaluation, we can see a multiple iris processes and bridging synechiae and a disorganized angle structures. And similar picture was seen in the left eye as well. This is the fundus photo, where we can see a bipolar thinning of the rim and a 0.9:1 cup disc ratio. But in the left eye, her rim was preserved with a healthy neuroretinal rim and a cup disc ratio of 0.5:1. So this is the IOP trend of the patient, wherein we can see the IOPs were not well controlled on maximum medication, and patient was advised to undergo trabeculectomy surgery in both the eyes eventually. So this is the OCT RNFL images of both the eyes of 2019 and compared it with the 2023 data, and we can see a progressive loss in the numbers of progressive loss of the RNFL in all the quadrants. Similarly, the similar picture was seen in GCC scans as well. And this is the visual field image of right eye, where we can see an advanced damage, whereas in the left eye, visual field was well preserved. So this is the IOP trend after both eyes trabeculectomy was done, and patient has been doing well after trabeculectomy and on no AGMs. So we even advised genetic testing for this patient, and it came out negative for all the known gene mutations, and whole exon sequencing was done for this patient. And this is a pedigree chart where none of the family members were affected.
So I think patient, it was like nothing came out. It came out as a sporadic, although it's a typical Axenfeld-Rieger syndrome. So sometimes I don't know, like it happens like that.
And whole exome sequencing, they only check for point mutations, ma'am, not for
Hmm.
deletions or duplications.
Yeah, that is what.
So, and only
Yeah.
60 to 70% of the patients come out positive for the known gene mutations. So there are so many gene mutations we are not even aware of right now. So coming to our next case, it's a 17-year-old male who visited for glaucoma opinion. He was already on timolol dorzolamide combination drops and prostaglandin analog in both the eyes. His visual acuity was 6 by 12 in both the eyes with a myopic refractive error. On systemic evaluation, we can see this facial profile with a maxillary hypoprominence and a flattening of the midface and a receding upper lip and a prominent lower lip. And in the side profile, we can see a micrognathia, and he also had a ambiguous umbilical skin tag. So on examination, his IOP was 23 in the right eye on 3 AGMs, and in the left eye it was 34 on 3 AGMs, and he had a high CCT in 650s in both the eyes. So this is a slit lamp image of the right eye where we can see a loss of normal architecture. We can see a correctopia, we can see stretch holes present and a posterior embryotoxon present with the peripheral anterior synechius present. Similarly, in the left eye, we can see a larger stretch holes present, a correctopia and posterior embryotoxon and peripheral anterior synechius. And on gonioscopic images, there was 360-degree pass with bridging synechia, and similar pictures were also seen in the left eye. So in this, we can see right eye optic disc was well preserved with a cup disc ratio of 0.5:1 and a healthy neuroretinal rim. Whereas in the left eye, he had a bipolar thinning and advanced loss of RNFL and neuroretinal rim with a cup disc ratio of 0.9:1. So in this GCC RNF, this is the images of GCC and RNFL where we can see the right eye images with the normal limits, whereas advanced loss is seen in both the eyes in the left. Advanced damage is seen on both the scans in left eye. And it was correlating well on the visual field as well. So right eye visual field were within normal limits, whereas in left eye we can see an advanced damage of the fields. So a diagnosis of Axenfeld-Rieger syndrome was made in both the eyes, and the patient was advised to step up anti-glaucoma medication for better IOP control. And IOP was controlled for some time, but then eventually it was uncontrolled, and both eyes trabeculectomy surgery was planned. So this is first the left eye surgery was planned because it had advanced damage, and eventually even the right eye IOP were not controlled. So right eye trabeculectomy surgery was also done. And this is the post-op day 1 image where we can see a diffuse bleb present in both the eyes. So the management includes parental counseling and education in terms of need for surgery, need for resurgeries, and management of the complications like squint or amblyopia or any keratopathy that developed due to this syndrome. Examination under anesthesia for severity of the disease and extent of glaucomatous damage is important. Treatment is both medical and surgical management depending on the age of onset, the severity of disease, progression, and IOP measurements. And more than 70% of the patient will require multiple surgeries. Surgical options include goniotomy, trabeculotomy, and trabeculectomy with mitomycin C and glaucoma drainage devices. In early onset glaucomas, trabeculotomy is favored over goniotomy due to presence of iris adhesions and a rudimentary Schlemm's canal. Mandal et al. Suggests trabeculectomy as a reasonable option in failed angle surgeries. In refractory cases, glaucoma drainage devices have been reported to be successful after a failure of conventional surgery, and no laser procedure have been proven effective in treatment of ARS-associated glaucomas. So, in this paper, they have discussed surgical outcomes associated with Axenfeld-Rieger syndrome, and they concluded that 70% of the patients with ARS have secondary glaucomas that often require multiple surgeries, and trabeculectomy with MMC and Barwell glaucoma drainage devices showed greater suspect. So, this is the table they had shown. In this, we can see trabeculectomy had success rate of 57%, and Barwell glaucoma drainage device had success rate of 70%, and whereas the other mode of surgical intervention has lesser surgical success rate. So this is a retrospective analysis of long-term surgical result and visual outcomes of early onset glaucoma in Axenfeld-Rieger anomaly, and they concluded that primary Combined TRAB and TRAB is a safe and effective procedure for early onset glaucoma associated with Axenfeld-Rieger anomaly. And this is a recent paper where they have discussed that Zen implantation in Axenfeld-Rieger syndrome is also have a promising result. So this patient had Axenfeld-Rieger syndrome, and the other eye was not doing very well with trabeculectomy surgery. So the patient was apprehensive to undergo trabeculectomy surgery. So Zen implantation was done, and this paper shows that the patient has been monitoring well on uncontrolled IOPs. So, to conclude, ARS is a rare genetic disorder with typical dental, facial, and ophthalmological clinical signs. And ocular defect in ARS are typically bilateral. Clinical diagnosis and management of pediatric glaucoma are guided by phenotypes. Genetic testing enables accurate genetic counseling, can reduce the risk of disease recurrence. And a holistic approach involves IOP management, both medical and surgical, and management of sequelae like cornea complications, amblyopia, squint, etc. Thank you.
Thank you for nice presentation. Like in these, especially in Axenfeld rigor, the prognosis for TRAB is pretty good. TRAB is because we do the TRAB later, maybe when the child is in the second decade or so. So it is good. Literature suggests that implants, but I never do implants as the primary procedure in these.
But that paper was showing goniotomy results to be pretty superior.
No,
17%, and
No,
the
no, no.
GDD results were 70%.
the
right?
GDD, but we don't.
43% for goniotomy, ma'am, and
Kitna?
43% for
Goniotomy
goniotomy,
may not be so.
and
43
13%, 17% for trabeculotomy.
That's
This
what
is,
trabeculotomy, and trabeculectomy
was 57%.
yeah. So
Trabeculectomy is
goniotomy
good.
and trabeculectomy was similar, but again, whatever little exposure I've had, goniotomy, would it work that well in Axenfeld-Riegers?
No, I have not.
What
I
would
don't
you
know.
say?
Sushmita can.
If the glaucoma is later, if it's a child which is later with a clear cornea, then you assume that the distal channels would have developed something. It's a later thing. So,
You
I
can
mean,
try.
I am so scared of the conjunctiva, frankly, especially when I tell my fellows 1, 2, 3, 4, 5, 6 at the most, if you've done your senior residency also, they're all very well. You get your gray hair and see them in 10 years' time, and those conjunctivas are bad. So we are proponents of moving away from conjunctiva. Of course, telling the parent that I'm doing this because I know it's less effective, but it's safer. And if it works, well and good. If it works in even half, I'm quite happy. 43. I would have said 50%. If somebody had asked me, I'd have said half my older children with Axenfeld do okay. Younger children, the babies that come, combined trab with trab is required. They need outflow. I don't think distal channels would be there for just a trabeculotomy. And possibly, I'm surprised that the trabeculotomy, that the trab with trab hasn't worked at all.
Yeah.
That doesn't make sense. If it's 57, where
Ma'am, in
is
this
No,
paper they haven't
trabeculotomy or
discussed that, but
this paper doesn't have trabeculotomy.
yes, ma'am. This does
other
not have
one.
combined.
No, it has combined.
Combined
This
works
has
well.
combined, this doesn't have
Yes.
trabeculotomy. So that's a little strange that they've done a
Yeah,
combined.
that's
So if a combined trab with trab is 17% and
that's
57% for only a trabeculectomy,
Ah.
to
It
me
did-
makes
it
no
did- it
sense.
did
I
Yes,
don't
yes, yes.
understand that.
But
Huh?
anyway, that's
No,
one.
sorry. It says trabeculotomy or combined. Oh, okay. So they've also
Plus
included.
minus trabeculotomy.
plus
Yes,
minus.
they've also included
minus.
only trabeculotomy. I don't think the two
Trabeculotomy
procedures.
may not work so
But
well,
plus
but
minus, just
trabeculectomy I
No,
have
but I
seen.
don't think you can combine them both
Yeah,
together.
yeah,
So
you
I would
cannot
say this is a
combine.
fallacy. You
Yes.
can't combine trabeculotomy and a trabeculotomy with trabeculectomy in the same group. So I'm not sure about that. But 53% for goniotomy is fair enough. Is about half. If it is an older
No,
child
but there are
in the second decade,
iridocorneal adhesions.
you go
So
above
you
that.
just
You go
sip it.
above that. Don't slit
Ah.
it. Go right above because the dysgenesis is
Only
still
the
there.
trabecular mesh works. So
Yeah,
you just
so
are
just-
dealing with the
just that.
trabecular
Once you go above them,
dysgenesis.
then it falls back, and then you can see the trabecular meshwork in there. Yeah.
It falls back. Just
So you
above.
would try it till what age? You said younger one you would not do it.
No,
So
no.
what's the cutoff? 4
So if
years,
they come
5
usually
years?
the second decade, the 10, 11, 12-year-olds,
So
where
you
we
would
do
tie
only a
that. You would
trabeculectomy.
tie- and you
So
want to
before
wait-
the trabeculectomy, I would do a.
And if the response comes, it comes immediately? If the
after
response
what?
has to come.
After goniotomy?
After
Yeah, the
goniotomy.
usual
Yes.
4 to 6 weeks, whatever you see.
So
The
then you
usual.
don't, if it then doesn't work in 1 month's time or 2 months' time, you go and do it surgery.
As and when
But
required.
I have
would
seen
do
in
that.
my practice trabeculectomy with
Yeah.
mitomycin because they are
That-
older children.
Yes,
Same
they're
here.
older
Same
So
here.
I think
Same
they,
here.
it
But
works reasonably
I
well.
would combine with the trabeculotomy
Ah,
always.
Yeah.
If I have a dysgenesis, I would not leave it at
It's
trabeculectomy
just
alone.
trabeculectomy.
Even the
Since I'm
older-
giving
Mm.
GA, I'm
Even
giving
the older
everything,
child.
I would, even
Yeah.
in older children,
Yeah.
do a combined
Combine.
trab with trab.
But I never understand, like after 10, 12 years of having glaucoma and dysgenesis, whether it can be corrected. Well, you have to make an alternate channel with
Meaning, what she's
trabeculectomy.
saying is you do a
Just add it.
trabeculotomy addition.
Addition.
Always.
Give an
Even in
additional
older
thing.
children.
Additional. Yeah.
Even I
Even
do
in
the same
older.
thing. Older children, maybe once you're entering it,
Yeah,
it's
once
a
you're
Yeah,
entering,
it
you
is
might
not,
as
it's
well
not a
do
big
it.
deal. You
Cut it.
can
Not a big
just,
deal.
yeah.
And it's easier sometimes in older children. Younger
Mm.
children, it's worse off. In
Yes,
older,
yes,
it's
yes.
easier
Because
to
because
it
the
is.
anatomy is not so
It's not so
distorted.
distorted.
Because the IOP hadn't risen initially. It's a late onset IOP rise, obviously, because there's no ophthalmos. The cornea is reasonably clear, so it's a more JOAG
Yeah,
kind
yeah.
of
Yes, yes, yes.
whatever phenotype.
So thank you.